Hi, Neil Lakdawala, Mike Gibson, Jim Januzzi coming to you live from HFSA, and we're talking about dilated cardiomyopathy, its genetics and treatment. Jim, talk to us a little bit about, where dilated cardiomyopathy fits into the heart failure landscape and where we're headed with treatment.
Sure thing. Yeah. So thanks, Mike. Um, when people come to the heart failure clinic with a reduced ejection fraction, we often partition them into ischemic and non-ischemic forms of heart failure. And there's an increasing recognition that a substantial percentage of the individuals who have reduced ejection fraction actually have a genetic basis for reduced cardiac function. And there are a large number of different mutations that may explain reduction in systolic function leading to heart failure. The challenge that we face for this population, number one, is an under recognition of how many people actually have genetic cardiomyopathy. But number two, we're treating patients essentially in a one size fits all approach rather than using therapies that specifically target the mutation leading to heart failure.
Yeah,
So,
that's right,
Jim,
Jim.
yeah, Jim, can you tell me, look, I'm not a heart failure doctor, but I play one on TV. So can you talk to us more about, how do we diagnose the genetic basis?
Well, let me ask Neil. I mean, there are ways of doing it with genetic testing, but I think that what viewers should know is just how grossly underutilized genetic testing may be, and if it was more commonly used, the exact incidence and prevalence of these mutations would be more recognized. Neil, what's your perspective on that?
Yeah, that's such an important point, Jim, and thanks for emphasizing it. Genetic testing for dilated cardiomyopathy is widely available through several commercial CLIA-approved labs. Yet claims data would suggest less than 1% of patients with this diagnosis get genetic testing, and that's despite over 30 years of knowledge of the importance of genetics and understanding the trajectory or natural history of disease. And frankly, it's the most common cause of dilated cardiomyopathy. We can identify a genetic cause in up to 30% of these patients. And based on those results, we can make real treatment decisions as to how we do things like use a defibrillator, offer prognostication. And what we're excited about as the next chapter is the development of precision therapies for this disease.
So, talk to us about danicamtiv and how that might be a good fit in this disease.
Thanks, Mike. Danicamtiv is a cardiac myosin activator, and it seems extremely well suited for primary cardiomyopathies where the cardiac sarcomere is mutated or variant. So we know that approximately 20 to 30% of patients who have dilated cardiomyopathy have this because of a gene variant affecting the sarcomere or the molecular motor of the heart. In those patients, there are less functional sarcomere units, and a drug like danicamtiv can increase sarcomeric interactions, prolong contraction, and increase the force of contraction. And so we tested in this study whether danicamtiv would improve cardiac function in patients who have sarcomeric dilated cardiomyopathy. We did it three ways. First, in vitro, we looked at some different model systems of mutated sarcomeres and showed that danicamtiv effectively increased cardiac function in those patients. Second, we were in those mutations. Second, in patients, we gave them danicamtiv and saw in patients who had sarcomere gene variants, there were significant increases in cardiac function using echocardiography. And last, we assessed the safety of this approach. And we did that a few different ways, one by monitoring for adverse events, but importantly for examining the relationship between danicamtiv drug levels and troponin release in the circulating, in these patients' circulation.
Yeah, you presented some results here at HFSA. Tell us what you found.
So we found exactly that. So we found that danicamtiv improved cardiac function. We specifically assessed function in the ventricle with LV ejection fraction, left ventricular global longitudinal strain, and we assessed the impact of danicamtiv on atrial function using the left atrial function index, which incorporates the left atrial emptying fraction and the velocity time integral across the left ventricular outflow tract. We assessed the safety, as mentioned, by reviewing for adverse events and for elevation in troponin. We found that in patients with sarcomeric dilated cardiomyopathy, the drug was effective, improved all those metrics of systolic function. with little or a very appreciable increase in troponin in relation to danicamtiv drug levels.
Well, that's reassuring to hear, Jim. You're one of the world's experts on troponin. Talk to us a little bit about, troponin, its release and its meaning in these kinds of patients.
Sure. So it's a really interesting question, Mike. The question of what troponin means in heart failure more generally continues to be an evolving story. What we know is that, generally speaking, and I'm speaking generally, not about in persons treated with myosin activators. What we know is that higher troponin concentrations in general heart failure is not a good thing. It is typically associated with cardiac remodeling and worse outcomes. However, in people treated with cardiac myosin activators, we see typically a very subtle increase in troponin at the higher dose ranges of these drugs, and it's never been linked to adverse outcomes, worse heart muscle performance, and if anything, an almost disconnection of the improved heart function and improved symptoms that these patients have. So it's an open question as to what it really means. Now, in our group at the Mass General Heart Center, we've actually done work looking at alternative means by which troponin might leave the cardiomyocyte. And it's kind of, sciencey to talk about this, but basically we found that you don't actually have to kill a myocyte for it to release some troponin, and it may very well be related to a completely benign process that these drugs exert. But at this point, we don't know. We're studying the question intensively right now.
That's going to be one of my favorite phrases, Jim. Kind of sciencey to talk about this. Thank you.
As a biomarker person, you have to, sort of simplify things
should not be.
sometimes.
Don't apologize. We're here to do kind of sciencey things. Well, Neil and Jim, congratulations on the presentation. Thanks for joining us today, and thanks to all of you for joining us for this update from HFSA.